everyone. I'm welcome to the latest webinar in our series of Travellers Talks with a variety of health and care topics. I'm Ruth Reaney. I'm the head of the health and care practice at Travellers, and along with my colleagues Dave Miller and Alexa Johnson, who are our lead underwriters, we welcome Helen Cooper and Scott McMurray from Delphi Care Solutions today. So thank you very much for joining us. Whilst we're just waiting for one or two more people to join, so it's just turned over, just going to talk about some of the other webinars we've done this year. So this is actually the fourth webinar that we have hosted so far in our series of health and care webinars, and we've also got two more lined up after this one. So if you're not already registered for those, do look out for the links. On the 24th of September, we have a session with Dr. Laura Haig, who's a chartered psychologist, and she will be discussing mental burnout and how to prevent that, which obviously in a fairly stressful environment that sometimes care can be. This should be a really, really interesting one. And then following Laura, we have Naomi Bailey, who'll be talking through allergies and strategies to manage patients and service users with allergies in a care setting. Again, a really, really critical topic, and that's on the 7th of November, so do look out for those. But back to today, we are delighted that Scott and Helen have joined us, and they're going to share their insights into the single assessment framework and what we know so far. So it should be really interesting. We're looking forward to hearing from them. And just very briefly, if you are a Travellers Care client, or if you're a broker who places care clients with us, I'm very pleased to share that we are partnering with Delphi to offer a care consultancy service to our clients. So look out for more information about that later on. But for now, over to you, Helen and Scott.
Great, thanks for that, Ruth.
Go on, Scott.
Great, so thanks for everyone for joining. As mentioned, the purpose of being here today is to share our insights with everyone on the call. In creating our content, we were really mindful that it was going to have a mixed audience joining, including brokers, underwriters, providers, people working directly on the front line. So we've hopefully captured content that's pertinent and relevant for everyone. And just an FYI, we do offer an additional sort of more detailed insights across the health and social care sector within primary care, social care and mental health services. But for the purpose of today, we'll focus on social care services, so typically residential with nursing, etc. And like I said, we've tried to kind of broad brush our content just to ensure we deliver it right for the audience. So just a disclaimer, just to kind of put it out there, all views are of Delphi's, not Travellers. We've created the content based on information in the public domain, taken directly from the CQC board performance reports, analysing public domain information such as CQC reports, but we've also leveraged some of our relationships with existing providers and suppliers to understand their first-hand views of and their experience within receiving inspections under the single assessment framework. So some of the learning outcomes we're hoping to achieve today is to deliver an awareness session on the single assessment framework, what we know so far, understanding the key components of the CQC single assessment framework, the quality statements and how to demonstrate compliance, and then how to evidence care in line with the CQC single assessment framework, and delve into some detail within the evidence categories as well. So CQC and their transformation, what we know so far. So the single assessment framework was first launched December 23. That was rolled out through regionally. So it started in the south of the country and it's now national. The single assessment framework is the framework used by the Care Quality Commission to inspect all regulated services. There is nuanced differences between primary care, secondary, mental health services, etc., typically within the evidence categories. But fundamentally, the quality statements are the same across all. So we'll introduce the quality statements and what they are. We'll discuss the new scoring system. Although the ratings remain the same, there is a new scoring system on how the CQC determine the ratings given to services. There's a new portal, which we're aware that some people have had challenges with and accessing, but also supplying information. But from some of the updates that we're seeing come through, that those challenges have now been fixed, and you should, as a provider of care, be able to submit all statutory notifications through the new portal system, and that's also the same for all new registration applications. think one of the big key changes within the single assessment framework is the greater focus on person-centred care and outcomes. And within our analysis of the evidence categories, it's roughly 66% of evidence, and how the CQC captures their evidence is feedback related. That's directly from people receiving care, stakeholders and commissioners commissioning care as well. So just some of the insights that we have seen through analysing the CQC's board performance report. So as you can see, through Q1 of 23 to Q4, year end of 24, end of the financial year, whilst there's been a significant decrease in number of inspections conducted, what we can see is there has been an average increase of the number of inspections triggered by feedback. That's typically serious whistleblowings, serious information of concern. So the CQC's risk-based strategy, there is some green shoots here to evidence that it is working and they are responding to risk. But it is just worth bearing in mind that the overall inspection activity has decreased over the last financial year. We'll speak about it a bit further on within the slide deck, but we do expect to see that change quite significantly with the leadership changes within the CQC, and the CQC also identifying themselves within their board performance risk reporting that the productivity of their operational team is not where they want it to be. So CQC insights and performance targets. Within this slide deck here, so we've captured it, included it for a number of reasons, but I think it's just really important to talk about the boxes that are in red. So for priority 1 whistleblowings, which are the more serious of whistleblowings in Q2, Q3 and Q4, 54% of those whistleblowings were actioned within 5 working days, which is a significant breach of their own internal KPIs. They aim for 95% of category 1 and priority 1 whistleblowings to be actioned within 5 working days. So again, under the new leadership team, we are expecting to see a real internal drive with the regulator to increase their workforce and their response to whistleblowing concerns raised. If we just think back to the previous slide where the regulator was responding to risk, and we can see that the proportion of inspection assessments, we are expecting to see over the next couple of quarters a significant increase in inspections triggered by feedback as well. For the brokers and underwriters on the call, or for the providers that are looking to expand their portfolio, the CQC have identified that there's a significant number of registration applications that's taken longer than 10 weeks to register. And this poses a number of challenges for providers that are looking to expand their portfolio. If you want to try and move quickly, it's difficult and challenging, but there's a few strategies to try and expedite your application, such as submitting the urgent application, which can be done within a month. For the brokers and underwriters on the call today, some of the deals that you'll be brokering for that might take longer to complete on because of the delay in the CQC registering or making a decision and making a notice of decision on whether it's a successful registration or not, could take over 10 weeks. So the insights on inspections and assessments continued. So with the rollout of the single assessment framework in December 23, we can see there was 101 inspections conducted as part of that rollout. Through January, February, March, we could see the number of single assessment framework inspections or assessments being conducted have outweighed those of the old methodology. So within the next quarter board performance reporting, we're expected to see 100% of inspection activity or assessments under the single assessment framework, with some caveats in there, such as historical reports and findings that have been challenged and have taken a significant longer time to be published, such as inadequate reports that have been presented at tribunal, etc. And the provider has been successful in challenging the CQC. So there will still be some legacy reports pulling through within the new reporting system, but fundamentally, as of now, you will receive an inspection under the new methodology. So the number of out-of-hours inspections, and the CQC's definition of this is inspections starting before 8:30, finishing after 6:30 p.m. and evenings and weekends. So what's really interesting about this metrics is the CQC are tracking it as an internal KPI. their internal KPIs for at least 10% of inspections to be conducted out of hours. And we are expecting to see this significantly increase with the new leadership team stepping in and significantly increasing the response to serious whistleblowings, etc., which would trigger a focused inspection. So enforcement action, I think it's very relevant to discuss. So whilst there's been a small increase in enforcement action, 0.5% increase in enforcement action overall, its trends is tracking very similarly to the previous year under the old inspection methodology. And you'll see the purple line is a significant reduction there, but the CQC is putting that down to a data lag. So it's their ability to pull the data out of the system, hence that significant decrease there. But in terms of the analysis and the comparables between the previous financial year and last financial year, the enforcement activities kind of tracking quite similarly. So additionally, just some additional CQC insights I think is really important to share with you. So whilst the CQC have assessed themselves for a number of areas, a number of key risks as exceeding their appetite but within tolerance, there's a few that are outside of that, so it exceeds tolerance. And one of those key ones are that the CQC have self-identified they do not transition well into new ways of working safely and effectively. Additionally, within this slide here, so CQC Insights Risk 2, we can see that the CQC have self-identified they do not meet stakeholder expectations, but they've also self-identified that their colleagues, the operational team, are not sufficiently engaged in the culture of change in the new ways of working. They've identified that their operational workforce is not as productive as it should be, and that they do not make accurate and timely assessments on the quality of care and risk for people using services. So just with this key risk information in mind, and the new leadership team, kind of stepping into post, whistleblowing, responding to priority 1 whistleblowings is significantly below internal KPIs. They've self-identified that the workforce is not as engaged as it should be. They've self-identified that the workforce is not as productive as it should be. So we would expect to see in the coming months a significant increase in the number of responses to whistleblowings, number of inspections being carried out, etc. So inspection process reporting, Helen?
Yeah, thank you. So inspection processes and reporting. So what do we know? We know that inspections are more flexible, specifically with respect to emerging concerns. It's evident from previous slides that whilst there's been a decrease of inspections, there's been an increase of inspections triggered by people's experiences and feedback. And we'll also show you in later slides where feedback from people's experiences, feedback from partners, and feedback from staff and leaders feature within certain quality statements and evidence capturing opportunities within the single assessment framework. We know that CQC utilises digital tools and data analytics to continuously monitor service performance. This hasn't changed, however, it does tie in with the drive for care providers to become digitised, if you're not already, and the introduction of the new portal for providers to share information electronically. As said, there's been an increase in unscheduled inspections based on people's feedback and emerging concerns, where early reports indicate between 15 and 20% increase of inspections either being triggered by data anomalies or complaints. So the report publication, within published reports, providers are able to see specifically which of the 34 quality statements they've been inspected against, along with the rating. And reports will generally give examples of the evidence determining the outcome. You will also see the reports remain online, however, they're no longer downloadable, but the provider will receive a copy. Next slide, please there, Scott. So perceptions from providers. So we've seen a mixed response to the single assessment framework, with some providers and register managers appreciating the ability to deep dive into the quality statements and being able to see clearly where there are areas for improvement, rather than a broad overview of a specific key question. Others have felt negative impact on their time with having to learn and understand the single assessment framework and pulling together the information to upload onto the portal when it's worked. A high number of providers have indicated the need for further training on the single assessment framework, and following the exit of the CQC's CEO and CQC statements that they're currently unable to keep people safe, there is a level of uncertainty, certainly with respect to what will happen next. So just next slide there, Scott, please. Insights on ratings and trends. So early implementation in the South showed a higher proportion of services had been rated good, suggesting an increase of good ratings from implementation start date. However, it's important to note here that both frameworks, as Scott mentioned previously, had still continued to be used. National stats across England show 15% of services were rated outstanding, 65 good, 15% requires improvement, and 5% inadequate. Regional examples, specifically in London, show an increase in outstanding ratings, though it's important to note here that not all of the inspections were comprehensive, and we do have a service rated outstanding to show later on in the slides as an example of this. So for further developments, following the CEO's exit, CQC have asked for provider feedback on how well people understand the new framework and approach. The feedback window closes on the 19th of July. So if anybody would like to share their thoughts and opinions, you've got until the 19th. And if people don't have the link to enable them to do that, we'd be happy to share that with people, and obviously with travellers as well, to pass that information on. So just next slide there, Scott, please. So introduction of the quality statements. So to better understand how to provide evidence for the quality statements, it makes sense that we first understand what they are. We know that the key lines of inquiry, the key questions, have remained the same. So we've still got safe, effective, caring, responsive, and well led. However, the prompts have now been replaced with 34 quality statements. The quality statements are pitched at a level of good, and are linked to the regulations, assisting the CQC to make their judgments on the quality of care being delivered. So just to the right of that slide, we've got a basic flow on how one feeds into the other. So we've got the key question, we've chosen effective. Within the effective key question are a number of quality statements. This one in particular is delivering evidence-based care and treatment. Underneath that, we have the we statement, and we statements are the commitment from the provider. So this one specifically for the quality statement is we plan and deliver people's care and treatment with them, including what is important and matters to them. And we do this in line with legislation and current evidence-based good practice and standards. Now, there are the I statements that go along with each quality statement, and this one in particular, but we've not covered it on this slide, but we do go into greater detail of the I statements later on. But just so providers know, the I statements give an opportunity for providers to check and evidence the feelings and lived experience of those receiving care, and where feedback is not so positive, to make sure that providers are documenting this and making sure that they are clear on actions taken to improve. So the link regulation to this quality statement, we've got regulation 9, 10, 12, 14 and 17, with also a consideration for regulation 11 as well. So provider evidence. In addition to the observations during CQC inspections and pre-inspection stakeholder feedback, evidence could be documentation such as good quality person-centered care plans, evidence of shared decision-making, and even reference to national best practice or NICE guidance where this has been used to inform specific decision-making. So next slide, please, Scott. Super, thank you. So the quality statements, as said, there are 34 quality statements, and here you'll see where each quality statement fits under each key question. So under safe, for example, we have learning culture, This has been highlighted in red specifically because we'll deep dive deeper into this quality statement on the next few slides. You'll also see that we've highlighted in yellow under caring, workforce wellbeing and enablement. Now this prompt previously sat under well-led, however, has now moved into caring. And this is with a view that if providers are caring and are supportive towards their staff, this should compound towards a better staff culture, resulting in a positive care environment for staff to work and residents to reside in. You'll also note that we've highlighted environmental sustainability and sustainable developments, also in yellow. This is covered under Regulation 17, good governance, though important to note that this is not currently rated. Whilst this is relatively new, this quality statement assesses how care providers understand and mitigate the negative impact of their activities on the environment. So when we look at evidencing this quality statement in particular, for this quality statement, it could be things like creating green plans or very simple ideas to reduce the carbon footprint, like car shares for staff or even bike to work schemes. Over to you, Scott.
Thank you. So as Helen's mentioned, we'll deep dive into the learning culture quality statement. We'll review the we statements, what it actually means, how it links back to the regulation, because whilst the single assessment framework's a new methodology, fundamentally the regulations have remained the same, apart from, I believe it's 9A, which is mandating visitors within social care services. We'll look at the I statements, and again, we'll just kind of talk through some of the evidence that providers can supply to demonstrate compliance with the quality statement of learning culture. So the we statement, which is a commitment that the provider needs and is expected to live up to, is that we have a proactive and positive culture of safety based on openness and honesty, in which concerns about safety are listened to, safety events are investigated and reported thoroughly, and lessons are learned to continually identify and embed good practices. So what does it actually mean? So it means that safety is a top priority that involves everyone, including staff, as well as people using the service, so those that are receiving the care and treatment within services. There's a clear culture of safety and learning based on openness, transparency, and learning from events that have either put people and staff at risk of harm or that have caused them harm. Risks are not overlooked or ignored. They are dealt with willingly and are seen as an opportunity to put things right, learn, and continuously improve. That raising concerns helps to proactively identify and manage risks before safety events happen. The incidents and complaints are appropriately investigated and reported, and lessons learned or lessons are learned from safety incidents or complaints, resulting in changes that improve care for others. This is linked to Regulation 12, Safe Care and Treatment, 16, receiving and acting on complaints, Regulation 17 of good governance, and Regulation 20 for duty of candour. So the I statements, that's the perceived lived experience of people using the service, developed in collaboration with TLAP, Think Local Act Personal. So the I statement that you'd expect to see within services that have a good learning culture is that I feel safe and I'm supported to understand and manage any risks, and that I can get information and advice about my health, care and support, and how I can be as well as possible, physically, mentally, and emotionally. So really considering the we statements, looking at the I statements, and actually what does the learning culture mean? Well, how do we translate and create evidence to demonstrate compliance and high level compliance of learning culture? One of the key pieces of evidence that you can collate is the feedback. So feedback from residents and people using the service. This could be done through surveys, daily feedback, citizen meetings, daily records, etc. Having high quality incident reporting metrics and analysing the data that makes meaningful changes to try and minimise incidents or near misses happening again. Having accurate, up-to-date training records to demonstrate that you facilitate and encourage staff to engage in high-quality training that supports the learning culture, such as incident management reporting, incident analysis, etc. Staff feedback is key here as well. So how do you capture staff's feedback to ensure that they feel able to raise concerns without having a punitive response, to have a clear and open culture where information is shared freely, risks are escalated appropriately, to try and with the primary aim to minimize risk to people receiving care and staff, and harm coming to staff. The quality improvement plans are a really good source of evidence here as well. So if you've got a number of work streams across directorates, across a number of homes, if you're a group of homes, for example, having centralized quality improvement plans where you're taking learning from one service to another, or if it's within a large, multi-floor building, you have got the quality improvement plans that you're sharing learning across each of your services or floors within the service where typically staff might not cross-migrate, etc. So now we're kind of deep to dive the learning culture, the quality statements, the we statements, and I statements. Well, how do the CQC actually make their judgments? So there's the evidence categories. So the CQC have developed 6 evidence categories that are used to consistently across all services to capture evidence. And out of the 6, for learning culture, the CQC apply 4 of those. And those 4 are people's experience, feedback from partners, feedback from staff and leaders, and processes. So each evidence category, similar to the quality statement, is rated on a scale of 1 to 4. And on the next slide, within 2 slides, we'll show you how to convert the scores of 1 to 4 into percentages, etc., which give you the overall score and rating for the service. But if we just focus on these 4 evidence categories, each of the evidence categories was scored as a 3, which is the equivalent to a good rating. So to work out your percentage, which will then link into your rating, you add up the maximum number available. So if there's 4 evidence categories and the maximum score each evidence category can have is 4, the total number is 16. You then add up the number that was awarded or given per evidence category. So in this example, each evidence category was given a score of 3, therefore the total number is 12. So you do the 12 divided by 16 calculation, which gives you 75%. In the range of the good rating, that's right in the middle. So it's a really good, high quality, good rating. So within the slide deck, so we've got all the links that takes you straight into the CQC's evidence categories across the sector groups as well. So as mentioned right at the beginning of the webinar, we'll focus on social care for the purpose of this webinar today. But there is some differences in the evidence categories used across directorates, such as primary care services, GP practices, patient transport services, mental health services, etc. The links are all live, they work, they take you straight to the source of information where you need to see, so we'll share these after the call. But the 6 evidence categories that are used across all regulated activities are people's experience of health and care services, feedback from staff and leaders, feedback from partners, observation, process, and outcomes. So the CQC and the scoring system. So the new scoring system, whilst the key questions, safe care and effective response, have been well, that remain the same, and the dots remain the same. So red is inadequate, amber requires improvement, green's good, and the blue star is outstanding. The score of 1 is the equivalent to inadequate, so that's significant shortfalls. Score of 2 is some shortfalls. Score of 3 is a good standard, and the score of 4 is an exceptional standard. The real benefit of when we work out the percentages that each quality statement is given is you can see very clearly where in the range of a good rating the service sits. So if they scored hypothetically a 64 for a specific quality statement, then we know that that's just above the threshold to achieve good. So there'll be 1 or 2 areas that within the evidence categories and within the quality statements that will be scored a 2, for example. So then that gives a provider the opportunity to make improvements within specific quality statements without having to have an overall requires improvement rating. So you can have quality statements within the safe key question that are requires improvement, but still have an overall good. And that's one of the real benefits of the new methodology. And we'll go on to give an example of that. So within the work that Delphi do day to day, so we support services proactively, identify risk, try and identify quality and compliance concerns, steer them towards good, but also respond to the regulator. So where there is significant concerns that the regulators raise, that our team, a multidisciplinary team, support them to make the transformation of quality within the service. This is a live scoring example for a service that we've done recently. And what you can see, if we focus on the safe key question, that learning culture was given a score of a 2, safe systems, pathways and transitions with a 3, safeguarding with a 2, involving people to manage risks with a 3, safe environments with a 2, safe and effective staffing with a 2, infection prevention control with a 3, meds optimization was a 1. So if we think back to the previous slide, where we know that 2 is the equivalent to a requires improvement, 3 is a good, 1's inadequate. So what does this enable us to do? So first of all, the service was rated requires improvement overall for safe, because their given score was 18 out of a maximum of 32, which converts into 56%. So historically, because of the number of concerns within this safe key question, they might have had an overall inadequate key rating, because meds optimization was on this occasion particularly poor. Under the new methodology, the single assessment framework, you can very clearly see which areas require improvement without having the safe key question as a blanket rating. So some work streams that the provider would create out of this is identifying additional ways to promote and improve learning culture, same for safeguarding as well, looking at the environment, trying to identify some additional strategies on how to get better with their safe and effective staffing. But fundamentally, the primary focus in this area would be the medicines optimization. So really trying to unpick that a little bit more. What we can see if we just focus on down at the bottom of this screen, where the 1 is equivalent to inadequate, on the range of 25 to 38, and then requires improvements between 39 and 62. So on this occasion, the provider for safe was rated given 56% compliance. So that's on the upper threshold of requires improvement. So with some focused quality improvement initiatives, the provider could achieve a good rating relatively quickly. The benefit, again, of the single assessment framework is the ability to submit evidence through to the portal, which can then be used for off-site inspection activity. So for key things such as like care plans reviews, risk assessment reviews, etc. If you're quite digitally mature and you have an EPR system, as an example, the CQC can request a login for this, and then they can analyze the care plans, risk assessments, etc., remotely without having to cross a threshold. The benefit of this is you can then increase your rating without actually having CQC assessment activity on site. Helen?
Super, thank you, Scott. So here we've got Harbour Rise Rest Home, and this is an example of an outstanding service recently rated under the new single assessment framework. Now, I need to note here that this information is readily available in the public domain, and we've used the following to give an example of CQC assessments under the new framework only, and we are not, as Delphi, in any way challenging the rating or questioning the quality of care delivered by the provider. So we've noticed previously that not all inspections under the single assessment framework are comprehensive, and are more often being referred to as an assessment rather than an inspection. And this one in particular is a good example of this. So you'll note out of the 34 quality statements available, only 2 throughout the whole assessment have been assessed by the CQC. These are highlighted in red under well led, with the number 4 just on the left-hand side, which, as Scott's gone through the scoring system, 4 is equivalent to the rating of outstanding. You'll see that responsive and caring key question also remains outstanding, yet not one of the quality statements under that key question or those key questions were actually assessed. So this kind of makes us wonder, how can we as the public and also stakeholders and investors be certain that this is an accurate reflection of the service if only 2 out of the 34 quality statements were assessed. So Scott, if you can open the report for me, just so we can show people where we're getting this information from and where people can find this information. So we're just on Harbour Rise. Yeah, I can see it, thank you. Just on Harbour Rise here. Scott, if you can open the report for me. Excellent, thank you. And if you jump into Well Led and scroll down. So just on the right-hand side there, you'll see the score of 4s, which show an outstanding rating. But you'll see under shared direction and culture, we did not look at capable, compassionate and inclusive leaders. We did not look at freedom to speak up. We did not look at, and as you go further down, you'll see some more we did not look at. But we've got governance, management and sustainability that was assessed by the CQC. Now within this, we probably expect to see governance documents being referenced, floor to board type thing. We do have a little bit in there about roast dinners for families, and that had gone down really well. The partnerships and communities, again, that was assessed by CQC with a score of 4 and outstanding, but there's no other quality statement that had been reviewed during this particular assessment. And as we'd gone through this particular report, what we'd actually found out, I think it was October, Scott, that they had a focused inspection where, again, not all areas, it wasn't a comprehensive inspection, but their last comprehensive inspection where all key questions were inspected was actually 2019. So whilst we're not saying that this service shouldn't be rated outstanding, and it's not a reflection on them or their service provision, it's important for lenders, private equity investors, underwriters and providers engaging specifically in mergers and acquisitions, that it's worth doing a deep dive into the report, current report, and also previous reports as well, to actually find out when a comprehensive inspection was last completed, just to give a well-rounded evaluation of the service. So we do also have a second example.
So if I could just add in there, Helen, just kind of, so just within that, so as Helen's mentioned, so providers that are looking at merger and acquisition or growing through acquisition, underwriters, etc., or brokers looking at, brokering on the insurance deals. Historically, some of the documentation that comes across the desk, you'll see the CQC published date, which in this case was June 2024. If you just take that on face value, then you'll make the assumption, or potentially make the assumption, that it was an outstanding service with all key questions rated outstanding. So just to really reiterate Helen's point around, do that your own due diligence around the timeline of inspections. When was the last comprehensive inspection? In this case, 2019, which was 5 years ago. Again, not challenging the CQC's judgment, but it is just more for the awareness of those that are particularly looking at the transactions of services or potentially underwriting on risk. Just to be aware that that last real comprehensive site visit was 5 years ago. Would you like the next one up now, Helen?
Yes, please, if you don't mind. Excellent, thank you. So here again, this is all information within the public domain, and this is specifically to highlight where CQC have not assessed specific quality statements, but again have carried over the good rating from previous inspections despite inadequate findings in other quality statements. So here we've got green waves. If you want to go into Well Led for me, Scott, please. So Well Led was rated inadequate. Now you'll see a lot more of the quality statements were assessed by CQC in this particular instance. So you'll see just on the top right there, we've got a score of 1, which is inadequate. And as Scott slowly scrolls down, you'll see the scores of 1. So all of these. So you'll see actually, if we just stop there and just do a pause, we've got freedom to speak up. Now this is rated a score of 3, which is good. But you'll note that this service, the CQC didn't look at freedom to speak up as part of their assessment. So whilst this is positive for the provider that they were able to carry over their previous inspection rating specifically for freedom to speak up, so CQC have been fair. If they've not assessed it, they've kept it as it is. But the downside of not looking into each quality statement is that the provider won't actually know how they are performing in that specific area. So if, for example, you've got your monthly quality audits and they're perhaps not as comprehensive as what they need to be, and it didn't pick up an anomaly or something wrong with the freedom to speak up section, you won't know that there's anything in that area that perhaps requires attention. So this specifically, coming back to Delphi, is where we differ in that unless a focused service review has been requested by a care provider, we'll always provide a comprehensive assessment of services. So we cover all 34 quality statements, and we appreciate that the CQC aren't doing that full deep dive or aren't always doing that full deep dive. But the benefit of this specifically to providers and registered managers is so they truly understand how their service is performing overall. And we will highlight opportunities for improvement, but we'll also celebrate good and exceptional practice as well. Thank you, Scott.
Definitely. So whilst I think it's also just important to add in here that under the new methodology, what we were seeing at the beginning of the rollout, the CQC would carry forward inadequate and requires improvement ratings as well. So they'll conduct an assessment inspection of a service focus, but they wouldn't always review the historical areas that was rated requires improvement or inadequate. The CQC have since changed their stance on that and made a commitment that any quality statement or key question that is rated less than good, they will always look at those when they cross the threshold or conduct a remote assessment activity. So I think that's a real positive. The next kind of downstream from that is the new registered services. They will receive a comprehensive site visit and comprehensive inspection and assessment as well. So, you know, those new to market that have not been rated historically, you should expect a comprehensive site visit. So I can get rid of those and we'll go back to the slide deck. So, as Helen's mentioned, so kind of what support's out there. So as a consultancy, we've got a substantive multidisciplinary team that includes general nurses, mental health nurses, forensic experience, etc. We've got occupational therapy and social work within the team, former CQC regulators and operational leaders that have worked with large corporate organizations. But additionally, we've also got the marketing and occupancy sales support as well for services that really want to try and optimize their operational performance through increased marketing and bed management, etc. We can support services with that. But really focusing on the CQC regulatory landscape, but also the risk management landscape as well. So we're an approved supplier to the NHS. We conduct serious incident investigations, including unexpected death investigations within the NHS services and the private sector. We support providers get ready for the CQC to try and optimize their opportunity for achieving a good or an outstanding rating. We do that in a number of ways, as Helen's mentioned, the comprehensive service evaluations and mock inspections. But we also have a number of tools that really help map out where your evidence sits. So if we think back to right at the beginning of the slide deck within this webinar, we're seeing the number of out of hours inspections increase. And so by having your evidence structured and readily available when the CQC cross the threshold out of hours, maybe the weekend, you know, through the night shift, etc., everyone within the organisation will know where the evidence sits. You know, you'll communicate it with your staff, so everyone will really be involved, which promotes a culture of that continuous improvement. So, and you know, that's just one of the number of ways we work with services. And that brings us to the end of the slide deck, and we'll open for questions. As you can see, we've got some in the chat box now, so I'll stop sharing my screen and then we can tend and answer any questions.
Sorry, I am here, Scott, but my video, can someone, whoever's turned my video off, can they put it back on, please? Thank you. There we go. Thanks.
Oh, yeah.
Right. I was like trying to get back off. I couldn't get my video back on. Thanks so much for that. There is a couple of questions in the chat, but as you know, I could talk to you guys about this all day, and I have so many questions. So I'm going to be really rude and just kind of pull out a couple of my own first, if that's okay. So I think you pulled out a really vital point for definitely for the underwriters and brokers on here about how the information is going to be presented is so much different from what we're used to. And it will just maybe take time for us to get our head around it. But to your point, I just hadn't appreciated how different it would be, and how I suppose the information that we used to get was very detailed in terms of each section, and it was very clear about how they'd arrived at their decision and who they'd spoken to and things. It's such a tiny snippet now of where they've got this from. And to your point, it could just be one question, and the rest of them have not been touched for 5 years. So it really doesn't give a very accurate reflection. And I think that's something that we just have to really remember, that we really have to dig behind the scenes a little bit. It's not just that front screen that we look at now that says outstanding or good. We do have to dig behind a little bit.
Definitely. So just to add a bit of context onto that as well, Alexa. So the public, as in, those accessing the CQC website, we can see which quality statements were reviewed, but what we can't see is, in the score for each quality statement. But what we don't get to see is what evidence categories were scored and what were used. So that's only the provider that will be supplied with that information. So for the brokers and the underwriters on the call, it might be worthwhile requesting, if they have had an inspection under the new methodology, just to get a sight of what evidence categories were reviewed and how they were scored within, that assessment. So as we've kind of tried to pull out within the webinar, you can still have an overall good rating, but you can have one or two of the quality statements as rated as the equivalent to requires improvement. Historically, with that, you probably would have had the requires improvement rating overall. So there's some real positives with the new framework. But if you are sort of brokering or underwriting on any of your policies, that if the provider is happy to share the information, I'd recommend that you review what the evidence categories were used and how they were scored as well. Yeah,
that's a good point. That was one of my questions, is that we don't see the percentages. We just, as a general public, we just see the overall score. So that is probably quite a good shout, is asking the provider to share that information. All the examples that we've kind of looked at here, and I've been through a few on the website, obviously they're all available, and they are already picking a few questions. I suppose 2 questions. When would they ever do a full comprehensive review? And on the other side of that, if they were going in on a specific targeted approach, but they saw something there that concerned them, would they then open that up to do a wider review? If you could answer that, I don't know.
Yeah, definitely. So the new methodology, we still refer to as new, but it's been here for a while now. The single assessment framework was very much geared up towards that risk-based approach, so responding to risk within the system. That's likely to change, and there has been some comms around that. So they'll be moving more back towards the planned inspection activities. So services such as requires improvement or inadequate ratings, we'd probably expect to see the old rules come out again. So 6 months for the site visit for inadequate ratings, 18 months thereabouts requires improvement. They could shorten those and pull them a bit closer. 3-month rule for the warning notice, etc. But to really just look at and answer your question, comprehensive inspections will typically be those that are inadequate overall, with inadequate and requires improvement ratings for each of the key questions, and those new to market, so those not rated before. That's where we'll see the comprehensive inspections. The focus inspections will typically continue to be where it's green shoots of good or a really good quality, good rating. They'll continue to be focused, we believe, at this time.
Okay. I think also, just to add on that point, Scott, like you said, with the inadequate requires improvement, we'll have a more comprehensive overview. Also based on risk, they maybe focus on, say, for example, if there are a number of whistleblowings or concerns raised regarding safeguarding, or if there's other concerns regarding staffing within the service or for the safety of the residents. It may be that CQC may focus on quality statements under safe and say well led, for example. But exactly like you say, Alexa, if there are significant concerns within the quality statements under each key line of inquiry, then that will naturally broaden as that inspection goes on.
Great, thank you. And so I better not hog you and actually ask you some questions from the audience. So we've got one in that says they'd be really interested to understand the types of information CQC have asked to see when they've had an inspection and how they've required that information to be sent to them, and also then how the in-person inspections are conducted. If you could maybe give a little bit of an overview about the change of the way that they're gathering the information.
Yeah,
Definitely.
absolutely. So Helen, do you want me to start and then you can jump in?
Go on then.
Great. So in terms of so focus on social care, so there'll still be you'll still supply the annual PIR. So every social care service will still the provider information return will submit that annually, but moving more towards the inspection activity, on-site inspections, that's a tangible physical information that they'd expect to see. So I think it's important to recognise that whilst this single assessment framework is a new framework, fundamentally the regulations remain the same. So providers that were historically good will more than likely remain good, with some upskilling of their staff, really making sure that people are bought in and are well trained with the single assessment framework. But tangible evidence, it's the quality auditing, the learning from events and outcomes, that continuous improvement programs, the quality improvement plans that they have. So the staff meeting, it's the typical stuff that you'd expect an inspector to request whilst you're on site. But then there's also the flip to that is that the CQC conduct off-site assessment and inspections. So that's where you can submit information remotely. You can give the CQC digital access to your patient record keeping systems, your EMR systems, etc. Or if you're quite digitally mature with the quality assurance frameworks, etc., that if it's all kind of sat within an app, or if you've got a specific piece of tech there that's managing that for you, then they may well choose to request that. But I think fundamentally, in our experience, we are still seeing the CQC focusing this on things that matter. So good quality person-centered care plans, good quality risk assessments that are updated regularly, the safeguarding logs to really ensure that they are being reported in a timely manner, appropriate actions being taken, strategy notifications are being submitted. But with that, we are also seeing additional trends and hot points or points of focus with the CQC. So that includes, right to work information, a real focus on modern slavery, the Schedule 3 recruitment checks. So historically, where people might have been given the benefit of the doubt if the recruitment records didn't always have employment dates right back to when people left school, you could kind of put a risk assessment in place and put appropriate measures in place. Whereas we are seeing it been treated probably as a little bit more of a higher risk. So, and there have been times where it's featured in warning notices, but that's where there's a real fundamental issue. Helen, was there anything else you want to add there?
Yeah, I think it's just the importance of the digitisation and providers. I mean, obviously, a lot of providers are now fully on board with electronic record keeping, but with the CQC's portal and easy, quick access, I mean, obviously, I know that there's been issues with the portal and that working properly, but once it is working and it's up and running, it's going to be much easier for providers to be able to send information over, which actually you're continuously giving the evidence to good quality, high quality care for people that reside in your service, which actually it's more likely to keep the CQC at bay from coming to site, because you continually updating. And as we've seen before, and as CQC said on a couple of their webinars, that actually if they requires improvement through the continual update and upload of information through the portal, they're more likely to be re-rated earlier than what the old framework would allow. So there are pros to the single assessment framework. I think it's just getting your heads around it. But I think something to reassure care providers specifically with is 9 times out of 10 people are doing and are delivering good quality care, and they have the systems and processes, they have the evidence and the good care planning and all of that sort of stuff. And I think people are under the misconception that they've got to do things a lot differently. They haven't. It is just understanding the key questions, the quality statements, the evidence categories, and we have developed a tool internally at Delphi that where we've kind of done a wireframe of sorts, where we've linked in where evidence would be would fit under certain quality statements under the key question, to try and help providers. And again, we'd be happy to speak with providers to discuss and share that information with them as well.
I think that's it, Helen. It's just it's the fear of the unknown, isn't it? And even though, you know, that to your point, nobody's asking them to do anything different. It's about it's just the way that that's communicated.
Yeah.
And perhaps until you've been through one of these, you just don't know, do you? And I think it is just that. And like you say, there was some teething problems to start with, and maybe that made people feel a little bit nervous that it perhaps wasn't going to work. But yeah, I think, you know, the fundamentally nobody's asking them to do anything different. So it will become the norm, and we'll all get used to it, I imagine.
Yeah, definitely. I think it's just to kind of conclude that point, that the big fundamental difference is that risk-based methodology, so responding to risk quicker. So whilst within this webinar we've identified that, you know, it's roughly 50% of priority 1 whistleblowers were responded to, the CQC are tracking that as an internal KPI. They will expect to see a significant improvement there. So with the risk-based methodology in mind and priority 1 whistleblowings, we will expect to see quicker responses in terms of on-site assessment activity. So the message to providers specifically is preparation's key. So just having your information to hand that everyone's aware of, they know where to find it. It's not just sat in the manager's office behind a locked door. It's readily available information, which demonstrates that kind of mature organisation. Everyone's involved in quality improvement. Everyone's involved in safety. It's, you know, it's common language. It's not when the CQC is asking questions. We've mentioned, you know, roughly 66% of evidence the CQC are using is feedback related, and a lot of that will be through conversations, interviews, off-site phone calls to staff, etc. So really, by having staff fully aware of your evidence, how you're structuring it, it's going to help them feel more involved and more confident when they're speaking to the inspection team.
So we're coming towards the end. Just a couple of things. Firstly, I think you guys have very kindly said that we can share the slides with people. Yeah. So I know quite a few people have asked whether they can have copies, so we can ensure that they're sent out to the participants today. And I think if anybody wants to get in touch with Delphi to either go through one of the mock CQCs, which I imagine would be really, really useful, or just generally to tap into any of their consultancy services, then by all means come to us, go to your broker, and we can make the necessary recommendations. And I think that was all I needed to say. So thank you both very much. It's been very interesting. And I know you have said that maybe we do another one of these in a few months and see whether things have changed.
Absolutely.
You know, let's just keep an eye, see what the trends are doing, and just update people. It's really useful. So thank you all so very much.
Great. Thank you.
Oh,
Thanks, everyone.
Thank you for having us.
Thank you.
See you then.
Take care.